Welcome back to Clinical Reasoning Rounds, Episode 4. Today we're dissecting 5 cases where the context is the key to the diagnosis. Whether it's a new medication, a travel history, or an immune state, the details matter. Let's sharpen our diagnostic skills. Remember, this video is for educational purposes only and does not constitute medical advice. Let's begin. Our format is straightforward. Each case unfolds over 6 steps: the history, including the crucial context, the examination, investigations like labs and imaging, your turn to decide, the reveal with reasoning, and finally, the clinical pearls. The most important part of this video is your commitment to a diagnosis before I provide the answer. Here is our case board. We have an elderly woman with an angry knee, a bruising patient, a teacher with chronic fatigue, a traveler with high fevers, and a transplant patient with a diagnostic dilemma. 5 different contexts. Take a moment to consider these, and let's get started with our first patient. Case 1. An 80-year-old woman presents with a hot, swollen, and painful left knee that started 2 days ago. She has no history of trauma. The most significant development in her recent medical history is the introduction of a new tablet in her medicine cabinet 6 months ago to manage high blood pressure. Keep that new medication in mind. Looking deeper into her history, we see that 6 months ago, she was diagnosed with hypertension and started on a thiazide diuretic. Her blood pressure is now controlled. She also has a history of mild hip osteoarthritis and occasional indigestion. There's nothing else of note. Could the new blood pressure medication be linked to this acute joint inflammation? On examination, she has a low-grade fever and clear signs of joint inflammation in her left knee, with a positive patellar tap. Notably, her hands show signs of chronic osteoarthritis, specifically Heberden's nodes. We must distinguish her background wear and tear from this acute, painful, and febrile condition. The physical findings point to a specific, localized issue. Investigations reveal elevated inflammatory markers and, surprisingly, a new, elevated glucose level. The knee X-ray shows osteoarthritis, but, crucially, no cartilage calcification. This is a key negative finding. We are looking for the cause of this acute inflammation, keeping the new diuretic and her recent metabolic changes in perspective. Pause the video and consider. What is the most likely diagnosis? Which specific item in her history is the culprit? And, critically, what single test is mandatory to confirm the diagnosis and rule out other potentially dangerous causes of a hot febrile joint? Your answer will define the next steps in management. The diagnosis is acute gout, precipitated by the thiazide diuretic. Thiazides can increase uric acid levels, leading to crystal formation in the joint. It is a common cause in this demographic. Crucially, we must always rule out septic arthritis first. Even with a fever and high inflammatory markers, a joint aspirate remains the gold standard for diagnosis. Aspiration provides the definitive diagnosis. Polarized light microscopy will reveal the needle-shaped, negatively birefringent uric acid crystals, characteristic of gout. This is distinct from pseudogout, which involves rhomboid-shaped, positively birefringent crystals. The procedure also helps exclude infection and can provide immediate symptomatic relief by decompressing the joint. Management involves treating the acute flare with an anti-inflammatory and replacing the culprit medication. Switching from a thiazide to an ACE inhibitor can help normalize both her blood pressure and metabolic profile. Remember these pearls. Always review the drug history, be aware of thiazide side effects, and trust the joint aspirate over symptoms or blood markers alone. Her history is striking for the absence of predisposing factors. No trauma, no medication use, no family history. The key is the combination of bleeding symptoms and profound fatigue. This pairing suggests a failure in the bone marrow's production of necessary blood cells, specifically those responsible for clotting and oxygen transport. We need to investigate her blood counts. Physical examination confirms signs of severe bleeding, purpura, oral blood blisters, and retinal hemorrhages. These are classic signs of significant thrombocytopenia. Her blood pressure is stable, and there is no organomegaly or lymphadenopathy. We are looking at a process that primarily affects the blood-forming elements within the marrow. Her blood work is concerning: severe thrombocytopenia and anemia, with an elevated white cell count. The clotting screen is normal, confirming that the issue is the number of platelets, not their function. We are seeing 2 cell lines failing, while one rises. What could possibly cause this pattern? Let's analyze the potential for marrow failure or infiltration. Pause the video. Consider the failed system: platelets, clotting cascade, or vessels. What does the pattern tell you? Next, identify the underlying diagnosis and the 2 tests needed for confirmation. Her clinical picture include a skin and mucous membrane bleeding, a low platelet count, and a raised white count. What process explains this? The diagnosis is acute myeloid leukemia. Her bone marrow has been overrun by malignant blasts, causing production of healthy cells to collapse. Her bleeding pattern is classic for platelet-type failure, distinct from deep hematomas seen in clotting factor deficiencies. This is a common presentation in older adults. Diagnosis requires a blood film to spot circulating blasts, followed by a bone marrow aspirate to confirm they comprise at least 20% of cells. While other conditions like myelodysplasia or vitamin deficiencies can cause similar blood count issues, only leukemia confirms this pattern of blasts. Keep this differential in mind. This presentation is an emergency. Management requires same-day hematology referral, supportive transfusions for platelets and anemia, and starting specialized treatment. Remember these pearls. Always investigate spontaneous bruising, distinguish between platelet and clotting factor patterns, and watch for retinal hemorrhages, which indicate a high risk for catastrophic bleeding. Case 3 involves a 63-year-old retired teacher experiencing a year of progressive exhaustion combined with numbness and unsteadiness in her feet. Her history reveals a mysterious color change in her eyes. These neurological and systemic symptoms occurring together point toward a specific metabolic failure. Her history tracks 2 distinct problems: systemic fatigue from oxygen transport failure and neurological impairment affecting her balance. Notably, there is a family history of thyroid autoimmunity. Autoimmune conditions often cluster together. These clues are essential for connecting her blood findings with her nerve symptoms. On examination, we see pale conjunctivae and a lemon-yellow tint to her sclerae. Neurologically, she displays a striking paradox: absent reflexes in her legs combined with extensor plantar responses. This combination indicates that both peripheral nerves and the spinal cord are being affected simultaneously by a single underlying cause. Her lab results show profound anemia with macrocytosis, meaning the red cells are abnormally large. The bilirubin is elevated while liver enzymes remain normal, indicating the cells are dying prematurely in the circulation. Her white cells and platelets are also dropping, suggesting the entire bone marrow is failing. Pause the video and answer these questions. What is the diagnosis and what is missing from her body? Second, why does she have this specific pattern of neurological findings? Consider the 2 structures involved in this paradox. Her anemia is macrocytic, and the history includes family thyroid disease. What connects everything? The diagnosis is pernicious anemia, caused by a vitamin B12 deficiency. Her immune system has destroyed the stomach's ability to produce intrinsic factor, which is necessary for B12 absorption. This leads to both ineffective red cell production and severe damage to the peripheral nerves and spinal cord. We confirm the diagnosis through serum B12 levels and specific antibody tests. While other conditions like hypothyroidism or folate deficiency can mimic parts of this picture, they cannot explain this specific combination of deep anemia and combined cord and peripheral nerve damage. Always check the B12 level in macrocytic anemias. Management requires urgent intramuscular B12 replacement. This is a lifelong treatment, since the stomach cannot recover. Caution is vital. Don't transfuse blood too aggressively, as this can trigger heart failure in patients with chronic severe anemia. Always prioritize B12 replacement to stabilize the nerves and heart. Case 4 introduces a 24-year-old worker who recently returned from Nigeria. He presents with rigors, intense episodes of shaking chills, followed by drenching sweats. After traveling to a region where specific infections are endemic, a fever is never just a simple illness. We must be highly suspicious of serious travel-acquired infections. His fever follows a classic paroxysmal pattern, which is highly concerning. Despite his use of anti-malarial prophylaxis, which he is still taking, he is symptomatic. Many patients believe that prophylaxis offers total immunity, but this is a dangerous assumption. We must consider that even with medication, an infection may have broken through. Examination reveals a tender spleen, which is a key physical finding in this context. His labs show falling hemoglobin and platelets, paired with elevated bilirubin but normal liver enzymes. This is a hallmark of hemolysis. Blood cells are being destroyed. This combination in a returning traveler requires immediate investigation for malaria. Pause the video. Question 1. What is the most likely diagnosis? And, since the answer lives on a glass slide, what exactly will the blood film show? Question 2 has 2 parts. First, does the anti-malarial prophylaxis rule your diagnosis out, and why? And second, Name the severe complications you must anticipate. The diagnosis is falciparum malaria. Parasites from a mosquito in Nigeria have been multiplying and bursting his red cells. The blood film shows these parasites in about 1% of his cells. Partial prophylaxis doesn't grant full immunity. It only lowers the odds. The hemolysis, thrombocytopenia, and tender spleen all confirm the diagnosis. Anatomy of a rigor: the cold stage with teeth chattering, the hot stage where fever spikes, and the drenching sweat. Remember the traveler rule. Any fever in someone returning from a malaria region is malaria until proven otherwise. This is the gold standard for your clinical practice, regardless of how well they feel between episodes. Treatment is aggressive. Treat hard and watch harder. Use current tropical disease guidelines as resistance patterns change. If the species is unclear, assume it is the dangerous falciparum. Monitor closely for severe complications like cerebral malaria, respiratory distress, and kidney failure. His low sodium is a red flag you must track closely. 3 pearls from this case. First, a returning traveler's fever is malaria until proven otherwise by a blood film. Second, prophylaxis is never a total shield. Tablets don't close the case. Third, recognize the triad of rigors, hemolysis, and a tender spleen. One final case remains, involving a patient whose immune defenses were medically turned down. Case 5. A 54-year-old transplant patient with a dry cough and a persistent climbing fever. She had a kidney transplant 18 months ago and has required increased immunosuppression for 3 rejection episodes. Now the guards are down in this house. This is a very different clinical challenge. Her medical history is a stack of risks. Her immunity is intentionally lowered to save her transplanted kidney. Crucially, her protective antibiotic, cotrimoxazole, was stopped at 12 months due to a rash. Now she presents with days of fever and a dry, non-productive cough. When an immune system is suppressed, the usual rules of fever change. Day 1, a fever of 38 degrees, but a clear chest and a normal X-ray. However, her lymphocyte count is dangerously low at 0.2, reflecting the heavy immunosuppression. She was initially managed with acetaminophen and asked to return if she worsened. It was a reasonable plan, but the real threat was just beginning to stir. 3 days later, her oxygen saturation is falling, yet her chest remains silent. This is the crucial takeaway. A normal chest X-ray plus falling oxygen means the X-ray is lying about the lungs. There is an unseen process affecting gas exchange. In an immunosuppressed patient, you must look beyond the plain film. Pause the video. Diagnosis. What is it? And what were the 2 key setup steps in her history? Next, how do you prove it? And why won't a simple sputum sample suffice? Your clues: low lymphocytes, the stopped antibiotic, and that silent hypoxia despite a clear chest. Think deeply about the host's vulnerability. The diagnosis is pneumocystis pneumonia. This fungus is usually harmless, but thrives when immunity is dismantled. She was set up by 2 things: the tripled immunosuppression for rejection and the loss of her prophylactic cotrimoxazole. The signature is fever, dry cough, and silent hypoxia. The diagnosis lives in the host, not just the symptoms. To prove it, use induced sputum or bronchoscopy with lavage, then stain the sample. Treatment is high-dose cotrimoxazole, but since she's allergic, we use alternatives like dapsone or clindamycin. With hypoxia, add corticosteroids early to blunt the inflammatory surge. Afterward, always restart a tolerable prophylaxis plan so her defenses don't stay down. 3 pearls. First, immunosuppression changes the rules of fever. Always consider opportunists. Second, trust the saturation probe over a clear chest X-ray for pneumocystis. Third, track discontinued medications. A missing shield is a standing risk. Context is everything. We've covered the cases. Now, let's summarize the habits of mind we've used today. Let's summarize. Case 1 teaches us that medications can be diseases. Case 2 shows that bleeding patterns reveal the system. Case 3 proves that B12 is essential for nerves and blood. Case 4 warns that fever in a traveler is malaria. Finally, Case 5 reminds us that in an immunosuppressed host, you must trust the oxygen, not the X-ray. Rounds complete. 20 patients diagnosed across 4 episodes. From gout to leukemia, pernicious anemia, malaria, and pneumonia, context was our primary tool. If these cases helped you, share this video and subscribe for our next session. New patients are already waiting. For education only, not medical advice. See you on the next round.